Very carefully. Seeing the tumor in the throat through an endoscope is not enough. The real danger is hiding beneath the mucosa. The cancer is silently eating through the cartilages. An endoscope can see the mucosal surfaces of larynx and hypopharynx, but it simply cannot see deep into the fat spaces or inside the cartilage framework. To see these hidden cancers spread beneath the mucosa, you need perfect local imaging. But which imaging modality will you choose? CT, MRI, or both? Does it matter to you if the imaging shows erosion, lysis, or penetration? Or are these three terms just different words for the exact same thing for you? Absolutely not. If you confuse these three terms, you will cause a catastrophic clinical error. Mapping the neck is only half the battle. What if the cancer has already escaped? If you miss distant spread to the lungs, you will put your patient through a brutal surgery for absolutely no reason. For a heavy smoker or a patient with swollen neck node, a chest CT is absolutely mandatory. And if the local disease is massive, you must unleash our ultimate weapon, the PET CT scan. It will light up the entire body and reveal the true burden of the disease. Today, I will give you a complete clarity on imaging for laryngeal and hypopharyngeal cancers. I will tell you what to choose and when to choose. Let us begin. Hello friends, before we begin, I am Dr. Parveen Ahlawat. I have been working at Rajiv Gandhi Cancer Institute, New Delhi since 12 years as a consultant. I did my MBBS and post-graduation from CMC Vellore. I then did my DNB from Rajiv Gandhi Cancer Institute and Research Center, New Delhi. I did a fellowship at Royal Marsden Hospital, London, and have later undergone a specialized training in cyberknife. I have published almost 85 research articles, including abstracts in international PubMed journals. I told you earlier that there are 11 steps for evaluating laryngeal and hypopharyngeal cancers. We have just finished our detailed discussion on OPD-based endoscopies and direct laryngoscopy in our previous lecture. You now know exactly how to properly map the superficial mucosal spread of a tumor even when you are sitting in OPD. But what is happening underneath the surface? An endoscope can see the mucosal surfaces of larynx and hypopharynx, but it simply cannot see deep into the fat spaces or inside the cartilage framework. It cannot see what is happening beneath the mucosal surfaces. To find the hidden disease, we must look beyond our naked eyes can see. This brings us to the highly fascinating world of local cross-sectional imaging. In this exciting new lecture, we are going to explore the absolute gold standards for imaging these complex cancers. We will learn the strict, standardized clinical protocols for how these scans must be acquired. We will discuss how to properly reconstruct these images to understand the true three-dimensional anatomy. And most importantly, we will learn exactly when to choose a CT scan and when you must ask for an MRI. Mastering this skill will completely change how you confidently stage your patients. Let us dive right into this very important topic. These are the two guidelines on local imaging for laryngeal and hypopharyngeal cancers I want all of you to go through. Before we go deep into the technical details, I want to take a moment to acknowledge these two guidelines. The first is a highly detailed guidelines by Dr. Arpita Sahu and her team. The second is an excellent paper by Dr. S.R. Priya and her colleagues. I want to express my sincere thanks to all these expert authors. They have done a wonderful job compiling such useful and practical information for all of us. Their hard work makes it much easier to understand the complex topic of local imaging for laryngeal and hypopharyngeal cancers. I also want to mention that I'll be using several excellent images from their published articles throughout my presentation today. These images are perfect for teaching and will help you clearly see exactly what we are discussing. I strongly advise every resident to download and read both of these articles completely when you have the time. Now let us dive deep into the world of local imaging for laryngeal and hypopharyngeal cancers. Before we look at the different imaging protocols, there is one absolute golden rule you must follow. You must always do your imaging before you take any biopsy. Always image first. Let me explain exactly why this is so important in our clinical practice. When you take a biopsy from a laryngeal or hypopharyngeal lesion, it causes local bleeding and swelling. It completely changes the normal tissue architecture. If you send this patient for a CT scan or MRI immediately after biopsy, the radiologist will see all this reactive inflammation. They will not be able to tell the difference between the actual cancer and the biopsy trauma. This will introduce diagnostic confusion and artifacts on the scan. It can very easily lead to overstaging of the tumor. So please remember this rule very clearly for your daily clinic. The scan must always happen before the knife touches the tumor. That is why in my work I started with OPD based endoscopies and then imaging. I will discuss direct laryngoscopy and biopsy after the imaging. We will now discuss our primary imaging tool. To know the extent of disease, we have an option of CT scan and MRI scan. Listen very carefully now. Contrast enhanced CT or CECT is our absolute workhorse. It is the definitive modality of choice for the initial evaluation of almost all laryngeal and hypopharyngeal cancers. I know many of you who are beginners in oncology and working in private and corporate hospital may find it difficult to digest when I say CECT is the initial local imaging of choice. I know you must have been doing MRI left and right for these tumors for local staging and workup. I am sure you like the soft tissue visualization of MRI. I am sure all these years you have been seeing your bosses doing MRI as an upfront imaging for laryngeal and hypopharyngeal cancers. But to be really honest, CECT is the initial first choice for local imaging. MRI has to be done as a problem-solving tools. If you want to pass in your practical exam, you must say CECT and not MRI. I will compare and discuss about this issue later in my slides. But for now, take my word, CECT is the imaging you will do, and let us move on. We must do local cross-sectional imaging for all laryngeal and hypopharyngeal cancers. But there is one very specific clinical exception to this rule. You do not need to order a CT scan for every single patient. Let us talk about an important exception. If you have a patient with an early T1A glottic cancer, this means the tumor is strictly confined to a single fully mobile vocal cord, and you have already planned to treat this patient with curative radiotherapy or cordectomy. In this very specific situation, you can safely skip the cross-sectional imaging. These lesions are so superficial that the chances of spread to deep structures are so less that you can completely skip imaging. But yes, I understand most of us in real clinical practice, we all do imaging for even T1A glottic lesion as a reflex investigation. But if you choose not to do, you are completely right. A thorough clinical assessment combined with a good microlaryngoscopy under general anesthesia is considered perfectly adequate. This is a very important practical point for your daily clinic. It saves the patient from unnecessary radiation and cost. But you must be absolutely confident in your clinical staging before you make this decision. Look at the technical parameters for acquisition of CT scan for laryngeal and hypopharyngeal cancers. Listen carefully. These are the absolute minimum requirements for acquiring a proper CT scan. You must be very specific when you write the request for your radiology department. First, you must ask for a multi-detector CT scanner. It should be at least a 16-slice machine. This gives us the high quality resolution we need to see very tiny details. Second, it has to be with contrast injection protocol. The radiologist must inject the iodinated contrast at a steady rate of 1 to 1.5 mm per second. This must always be followed immediately by a proper saline flush. Finally, look at the third and most critical parameter. Timing is everything in these scans. The images must be taken strictly in the venous phase. This means there must be a clear delay of 60 to 90 seconds after the contrast is injected. Why do we wait for this specific time? This delay allows the contrast to fully reach and highlight both the normal soft tissue and the actual tumor. If you scan too early, the tumor will not enhance properly and you will miss the exact borders of the disease. You must remember that larynx is a very small and highly complex organ. Standard thick CT slices will simply miss the tiny details we need to see. Therefore, you must specifically ask your radiologist for thin angled cuts through the larynx. Thin and angled cuts. These cuts must have a very high spatial resolution. The absolute maximum slice thickness you should accept is 1.25 millimeter. If the slices are thicker than this, the scan is simply not adequate for proper oncological staging. But if your center has an advanced machine, you should always aim for the best possible quality. The ideal target for slice thickness is 0.6 millimeters. This micro thin resolution gives you the maximum possible image clarity. It allows you to clearly see the exact soft tissue borders and the delicate cartilage framework. Now let us talk about how we view these very thin slices on the computer screen. This brings us to the very important concept of multiplanar reformatting. Multiplanar reformatting. Let us clear up a very important confusion about these images. When I say multiplanar reformatting, it does not mean we ignore the standard axial images. In fact, the CT machine always acquires the original scan in the axial plane from top to bottom. We absolutely must look at these axial slices first to check the bilateral symmetry, the vocal cords, and both the commissures. But we simply cannot stop there. Because the larynx is a complex vertical tube, looking only at flat cross sections will make you miss the upward and downward spread of the tumor. This brings us to the very important concept of multiplanar reformatting. Multiplanar reformatting simply means using the computer software to take those thousands of thin axial slices and mathematically rebuild them into clear side and front views. First, let us talk about the sagittal plane, which is your side view. There are many structures you can see better in sagittal plane. While an axial slice only shows a flat circle of pre-epiglottic space, the sagittal view beautifully shows its entire vertical height. It is absolutely the best plane to see if an epiglottic tumor is spreading upward into the base of the tongue or downwards toward the petiole. Next, we have the coronal plane, which gives you a direct frontal view. Axial slices can make it very difficult to understand if a tumor is crossing from false chord down to the true chord. But the coronal view lets you easily trace the exact vertical spread of the disease along the side wall of the larynx. It is strictly required to assess the deep paraglottic space and to see if the laryngeal ventricles are involved. Now let us discuss how we actually look at the soft tissues and the bones. You do not need to scan the patient twice to get these different views. The soft tissue windows and the bone window are simply digital display settings on the radiologist computer monitor. Once the scan is done, the radiologist simply adjusts the contrast and brightness levels on the workstation screen. You first use the soft tissue window to clearly see the tumor mass, the normal muscles, and the fat spaces. Then, with a simple click of a mouse, you change the display to the bone window. This specific setting makes the soft tissue turn dark and brilliantly highlights the dense calcium inside the laryngeal cartilage. This is the only reliable way to catch any very early subtle erosion of the thyroid or cricoid cartilage. You must train your eyes to actively switch between these two computer windows in all three anatomical planes during your daily practice. There is a highly practical aspect of acquiring a good scan. Even if you have a best CT machine in the world, patient movement will completely ruin your images. The larynx is constantly moving during our normal daily activities, including breathing and swallowing. Therefore, you must clearly instruct the patient to lie completely flat in the supine position and just breathe very quietly. But here is the absolute golden rule you must strictly tell your patient before the scan begins. They must absolutely not swallow and they must not cough while the scan is being done. I know this sounds very simple, but it is actually quite difficult for a patient who has a throat tumor and extra saliva. Any swallowing or coughing causes severe motion artifacts on the images. These motion artifacts blur these exact soft tissue borders and make it impossible for us to accurately stage the tumor. So always take a minute to properly counsel your patient about this before sending them into the CT room. Tell them the importance of this. We just talked about keeping the patient comfortably still, but sometimes we actually want the patient to do something very specific and actively. This brings us to the use of dynamic maneuvers. See, many spaces inside the throat are normally completely closed or collapsed when we rest. If we just take a regular scan, we might miss the tumor hiding inside them. So we ask the patient to perform two simple actions while the machine is scanning. First is continuous phonation. You tell the patient to say a long E sound. This simple action clearly opens up the laryngeal ventricle. It helps you see if the cancer has spread between the true and false vocal cords. The second action is the modified Valsalva maneuver. Here, you ask the patient to bear down and push hard. This builds up air pressure inside the throat. This pressure completely opens up the deep hypopharynx. Without this step, the walls of the hypopharynx lie flat against each other. You must use these simple tricks to get a highly accurate picture of the disease. I know these maneuvers may sound weird to you, but without these weird tricks, tumors hiding deep inside these collapsed spaces can be completely missed on the scan. Now let us talk about the biggest practical drawback of using a CT scan. A CT scan fundamentally overestimates the true extent of the tumor. It overestimates the true extent of the tumor. Let me explain the exact mechanism behind this common clinical pitfall. A CT scan heavily relies on soft tissue thickening and contrast enhancement to show us the disease. But you must remember that a cancer in the throat always causes a lot of local swelling and inflammation. The CT scan cannot tell the difference between the actual cancer cells and this surrounding reactive edema. Both the tumor and the inflamed normal tissue will enhance and look exactly the same on your computer screen. This means the disease will almost always look much bigger on CT scan than it actually is in reality. This is a very dangerous situation for a resident. It can easily lead you to overstage the tumor and deny the patient a chance at voice preservation. This is exactly where an MRI becomes our best friend. We will see how an MRI helps us solve this exact problem in our next slide. We just saw how a CT scan can easily confuse us with reactive edema. This is exactly where we bring in the MRI of the neck. You must understand that an MRI is not our routine first-line scan for every single patient. We use it specifically as a complementary problem-solving tool. You should order an MRI when your CT scans leaves you with borderline or confusing findings. It has two highly specific capabilities that you must remember for your clinical practice. First, an MRI gives us the far superior soft tissue contrast. This allows it to clearly differentiate the true margin of the tumor from the surrounding inflammatory edema. It helps us avoid falsely overstaging the disease. Second, and perhaps most importantly, MRI is the definitive test for evaluating cartilage invasion. CT scan can sometimes miss very early cartilage erosions because the normal calcium distribution is often irregular. But an MRI will clearly show you if the tumor has entered the marrow space of the thyroid or cricoid cartilage. If you are planning any organ preservation surgery, this precise information is absolutely critical. Let us quickly summarize the standardized clinical workflow we just learned. This is your practical daily checklist for laryngeal imaging. First, you must always image the patient before taking any biopsy. This single rule will save you from endless diagnostic confusion caused by tissue trauma. Second, your default workhorse is always a contrast-enhanced CT. But you must ask the radiologist for a venous phase with a 60 to 90 second delay. Third, ask for micro thin slices of less than 1.25 millimeter, ideally 0.6 millimeter, and train your eyes to actively review both the sagittal and coronal reconstructions. Fourth, do not forget the power of dynamic maneuvers. Simple actions like continuous phonation and the modified Valsalva maneuver will mechanically open up those collapsed hidden spaces. Finally, know exactly when to escalate to an MRI of the neck. Use the MRI specifically as a problem-solving tool. It is your best weapon to resolve confusing reactive edema and to definitely rule out deep cartilage invasion. Keep these 5 golden rules in your mind for every single patient you evaluate in your clinic. Now let us start seeing some real images of the laryngeal and hypopharyngeal region. There are going to be a lot of images in my next slides. I will first show the normal cross-section anatomy and then I will move to imaging showing tumors. Look at the anatomical diagram on your screen. Before we start analyzing complex scans, we must quickly revise the normal vertical divisions of the larynx. This is absolutely essential for accurate T-staging. The larynx is divided into 3 distinct vertical zones. First, look at the uppermost region labeled as the supraglottis. This area starts from the tip of the epiglottis and goes all the way down to the laryngeal ventricles. Now look closely at the area marked by the small red vertical double arrow. This represents the glottis. Notice how the glottis is actually a very narrow zone. It is strictly defined as a vertical space measuring just 1 centimeter in height. It includes the true vocal cords and extends exactly 1 centimeter below them. Finally, look at the lowest zone highlighted in yellow. This is subglottis. It starts immediately below that 1 centimeter glottic line. It extends downwards and ends exactly at the inferior border of the cricoid cartilage. You must keep these exact vertical boundaries clearly in your mind. We will use these exact landmarks to track tumor spread in the CT scans on our next slides. Now let us apply the anatomical zones we just learned to actual patient scans. Look at the coronal CT scan labeled as image A on the left side of your screen. This image demonstrates those 3 precise vertical subdivisions in a real patient. Look closely at the space between the top blue line and the white line. This represents the normal supraglottis. Next, look at the very narrow vertical zone between the white line and the green line. This is your exact 1 centimeter glottic space. Finally, check the area between the green line and the bottom orange line. This clearly shows the normal subglottis. Now let us shift our focus to the right side of the screen to look at the cartilages. Look at the axial CT slice labeled as image B at the top right. Please note the normal thyroid cartilage, this one. Now look at the normal cricoid cartilage, this one. Next, look at the axial MRI slice labeled as image C at the bottom right. This is a specific T2 weighted MRI. Notice how the cartilages look slightly different here compared to the CT scan. This is the normal thyroid cartilage and this is the normal cricoid cartilage. You must train your eyes to instantly recognize these normal anatomical landmarks. Let us now look at the normal anatomy of sites of larynx, supraglottis, glottis and subglottis, and sites of hypopharynx, the piriform sinus, posterior pharyngeal wall and postcricoid region. Let us start with the normal anatomy of supraglottis. Look at the axial CT scan on the top left of your screen. See here. Look at the areas marked by yellow arrows. These are bilateral air-filled spaces known as valleculae. Look closely between and around these spaces to identify the midline median glossoepiglottic fold as well as the 2 lateral glossoepiglottic folds that border the valleculae. Now look at the red arrow pointing to the midline structure. This is the free edge of the normal epiglottis. Notice how this structure has 2 distinct surfaces, the anterior surface the anterior part facing the tongue is the lingual surface of epiglottis, while the posterior aspect facing airway is the laryngeal surface of epiglottis. Now look at this image in the top middle. Look at the purple arrow. It is pointing to the dense normal hyoid bone. Now move to the image on the top right. Look closely at the structures indicated by the dark blue arrows. These are the normal airy epiglottic folds. Next to them, look at the areas marked by the light blue arrows. These highlights the lateral fat-filled paraglottic spaces. Let us move down to the bottom left image. Look at the area marked by the orange arrow at the very top. This is the crucial fat-filled pre-epiglottic space. On the same image, look at the light blue arrows showing the deep continuation of the paraglottic spaces. And please note the brown arrows pointing to the bilateral pyriform sinuses behind the larynx. The pyriform sinuses is one of those three major subsets of hypopharynx. As we evaluate these scans, you must always also be aware of the other two hypopharyngeal subsites seen in this region: the postcricoid area and the posterior pharyngeal wall. Finally, look at the image on the bottom right. Look at the areas marked by the two upward pointing yellow arrows. These are pointing directly to the normal false vocal cords. Look just behind this area. Here, you can also clearly appreciate the normal paired arytenoid cartilages. Now look at the solid red arrow on the right edge of the same image. It shows the normal thyroid cartilage. You must become very familiar with these normal fat spaces and cartilages. Recognizing this normal baseline anatomy is the only way you will be able to spot early subtle cancer spread in your patients. Let us move further down the larynx to examine the normal anatomy of the glottis. These are two CT slices taken at the level of vocal cords. Look at the structures marked by the two yellow arrows pointing downwards. These represent the normal, perfectly symmetric true vocal cords. Now look just behind them at the areas marked by the blue arrows pointing upward. These highlight the normal, dense arytenoid cartilages. Next, look at the axial CT scan on the right. Look at the red arrow pointing directly to the front midline, where the two vocal cords meet. This is the highly critical anterior commissure. Notice how there is normally almost no soft tissue thickness at this point. Now look at the purple arrow on the right side of the same image. It is pointing to the normal thyroid cartilage. Finally, look at the blue arrow pointing to the midline area at the back. This shows the normal posterior commissure. You must rigorously train your eyes to ensure these commissures and true vocal cords are completely clear and symmetric in every single scan you evaluate. Move further down to final and lowest zone of the larynx, subglottis. This is the normal cross-sectional anatomy of the subglottis. Please look at the soft tissue axial CT scans on the left side of your screen. Look at the structure indicated by the orange arrows. This is pointing to the normal cricoid cartilage. Notice how the cricoid cartilage form a complete solid ring around the airway. Now look at the light green arrow on the far left of that same image. It is pointing to the normal contrast enhancing thyroid gland. You can clearly see how the lobes of the thyroid gland wrap closely around the outside of the subglottic airway. Next, see the image on the right. This is the exact same CT slice but in bone window. Look at the orange arrow again. Notice how brilliantly the dense ossified framework of the cricoid ring is highlighted against the darkened soft tissue. You must rigorously check the entire ring for any subtle breaks or erosions when evaluating a patient for deep subglottic tumor spread. Now let us shift our focus from the larynx and look at the normal anatomy of the hypopharynx. Look at image A on the left side of your screen. Look closely at area highlighted by the blue rectangular box. This box clearly outlines the normal vertical extent of the hypopharynx. Notice how it sits directly behind the laryngeal framework and extends downward. Now see the axial CT scan on the right. Look exactly where the straight white arrow is pointing. This points to the normal post-cricoid region. This is one of the three major subsites of hypopharynx. You can clearly see how it forms a thin layer of soft tissue immediately posterior to the cricoid cartilage. The other two critical subsites of hypopharynx are the bilateral piriform sinuses and the posterior pharyngeal wall, which are not visible in these sections. You must always evaluate these three specific subsites very carefully. Because hypopharyngeal tumors have a strong tendency to spread under the mucosa, their true extent is very easy to miss on a routine clinical examination. With this, we completed looking at the normal anatomy of larynx and hypopharynx. Now I'm going to start showing you abnormal cross-sectional images of the laryngeal and hypopharyngeal lesions. But before that, look at the checklist on your screen. This slide summarizes exactly what you must actively look for when reading any cross-sectional images for laryngeal or hypopharyngeal cancers. First, you must assess the spread of the tumor across the anatomical sites of the larynx. You need to clearly define if the mass is crossing from the supraglottis down to the glottis or into the subglottis. Second, look closely for any spread into the deep fat compartments. This is assessed by looking for the effacement of the normal fat inside the pre-epiglottic and paraglottic spaces. Third, you must actively hunt for any erosive changes or transmural spread through a laryngeal cartilage. Remember that the most commonly invaded framework is the thyroid cartilage. Fourth, check if there is any extralaryngeal spread where the tumor breaks completely out of the larynx and into the surrounding neck soft tissues. Fifth, systematically evaluate all the neck levels for any nodal involvement. Finally, always remember to screen for distant metastasis. The most common site for distant spread in these patients is the lungs, which is exactly why a chest scan is so important. You must strictly follow this exact evaluation checklist for every single scan you review in your clinical practice. Before we go on to learn abnormal imaging of laryngeal and hypopharyngeal cancers, let me show you the most critical and challenging aspect of laryngeal and hypopharyngeal cancer workup and staging. It is the evaluation of thyroid cartilage invasion. Listen very carefully now and pay attention. I am going to teach you how to evaluate thyroid cartilage invasion using our daily workhorse, which is the standard conventional single contrast enhanced CT scan, which most of us have at our hospitals. As radiation oncologist, you must master this skill because cartilage invasion determines whether you can safely preserve the larynx with chemoradiation or if the surgeon must remove it entirely by doing total laryngectomy. Look at the detailed slide on your screen starting at the very top. Let us first look at the left side under negative findings. How do we confidently say that a tumor has not invaded the cartilage? We look for two very specific structural signs on the CT scan. First, look at the green arrows in the top left drawing. They point to a very thin, dark, hypoattenuating line that naturally separates the tumor from the cartilage. Can you see this here? Now look directly below that drawing to the actual CT scan labeled B on the middle left. Follow the black arrows. You can clearly see this intact dark line beautifully preserved between the tumor mass and the thyroid cartilage. See here. As long as you see this protective dark line, the cartilage is safe. That means it is uninvolved. The second sign of a negative scan is a clear difference in tissue density. Look at the CT scan labeled C on the bottom left. The black arrows show the normal unossified cartilage. Notice how its gray color and density are completely different from the adjacent dark tumor mass marked with the letter T. Now let us shift our focus to the right side of your screen under positive findings. When a tumor does invade the cartilage, we classify the damage into three specific categories depending upon the severity of its involvement. There are three very important terms here. We must understand it clearly. You must understand exactly what these three terms mean. The first term is erosion. Erosion means the tumor has broken through the inner lining of the cartilage, but it involves less than half of the total cartilage width. It has not reached the outer border yet. This is the inner lining or inner cortex, and this is the outer lining or the outer cortex of the thyroid cartilage. See here that tumor has gone through the inner lining of the cartilage, but it involves less than half of the total cartilage width. The outer cortex is completely uninvolved. This is called erosion. The second term is lysis. Lysis is much deeper and more destructive. It means the tumor has eaten away almost the entire width of the cartilage, but the outer cortex is still barely intact. Look at the actual CT scan labeled C on the bottom right to see lysis in a real patient. Look at the black arrows. They show that the protective dark line we talked about earlier has completely disappeared. Now look at the white arrowheads right next to them. They clearly show that the normal cartilage space has been physically substituted and replaced by the actual soft tissue tumor. The third and final term is extralaryngeal spread, also called as transmural spread. This is the absolute worst case scenario. It means the tumor has completely penetrated through both the inner and the outer cortex of the cartilage. The cancer has successfully broken out of the laryngeal framework and has gone directly into the soft tissue of the neck. This is a complete all-layer invasion that penetrates completely through both the inner and the outer cortex. Look at the CT scan labeled B on the middle right. Follow these two white arrows. You can clearly see the tumor pushing through the outer boundary of the thyroid cartilage and into the surrounding neck tissues. This finding instantly makes the disease a T4A stage. You must train your eyes to actively search for these exact structural signs on every conventional CT scan you review. However, conventional CT scan have one massive limitation when evaluating these structures, which often leads to false positive. What we are seeing here is the standard conventional single energy CT scan which most of us have at our hospitals. It has a biggest, most dangerous limitation. Actual cancer tissue and normal unossified cartilage look exactly the same on a standard conventional single energy CT scan. They both have similar tissue density of about 100 Hounsfield unit. This similarity in density between cancer tissue and normal unossified cartilage creates the dreaded T3 versus T4A dilemma. It is the exact reason why we frequently overstage patients, falsely calling a scan positive for invasion. So how do we solve this diagnostic problem? This is solved by a further advanced technology of doing CT scans. Instead of doing standard conventional single contrast enhanced CT scan, we do a special CT scan called as dual energy CT scan, often called DECT, dual energy CT scan. Listen very carefully to understand this advanced form of CT scan. Look at the two rows of diagrams on the left side of your screen. These ones. The top row shows WA images, which means weighted average images. These images are mathematically generated to mimic a standard CT scan, allowing us to clearly see the structural boundaries. These WA images are just like our routine images we get on our standard conventional single energy CT scan images. Just like your standard conventional CT images, WA image provide the baseline high spatial resolution anatomical framework. You use them to identify the physical boundaries of the laryngeal cartilages and to look for macroscopic structural defects such as the disappearance of the protective dark line on the presence of frank erosion and lysis we saw in previous slide. However, because they act just like a standard single energy CT, they also share these exact same clinical limitations. On a WA image alone, an infiltrating tumor and normal unossified hyaline cartilage will look identical because they share the same density overlap of about 100 Hounsfield unit. This is exactly why the standard looking WA image must be paired with a special type of image using dual energy CT scan. This additional image is called IO image, iodine overlay image, iodine overlay image. You can acquire IO image only on dual energy CT scan. What is so special about these IO images? These IO images maps actual blood flow to definitely prove if that structural defect is truly an invading cancer. These are specialized color maps that specifically isolate blood flow and iodine contrast. This is the true game changer in laryngeal imaging. See, squamous cell carcinoma is highly vascular tumor. So, it will strongly light up red with iodine on these maps. This is shown as red tumor in these diagrams. But normal unossified cartilage has no blood supply at all. So it will show absolutely zero iodine uptake. This is shown as without any color in these diagrams. There is a scoring system to assess the severity of cartilage invasion. Look at how we strictly score cartilage invasion using these two images together. Look at the left side under negative findings. A score of 1 or 2 means the cartilage is completely safe. That means it is uninvolved. The tumor has not invaded cartilage at all. You should be able to see an intact dark line between the tumor and cartilage on the WA image. Importantly, you should be absolutely not seeing any red colored tumor tissue inside the cartilage on the IO image. Now look at the right side under positive findings. Here the cartilage is involved. How do we assess the severity of such cartilage invasion? A score of 3 definitely indicates erosion. A score of 4 indicates deeper lysis. And a score of 5 means complete extralaryngeal spread. These are scoring system 3, 4 and 5. To confidently call a scan positive or say cartilage is involved or infiltrated, you must see the structural defect on the WA image and you must see the red vascular tumor on the IO image. Requiring a positive findings on both of these images pushes our diagnostic specificity to over 96%. Now, you might be asking yourself a very practical clinical question. How common is this? And is it really required for every single patient? The simple answer is no. Current guidelines on imaging for laryngeal and hypopharyngeal cancer do not mandate dual energy CT as the standard of care. Your daily workhorse remains the standard conventional single energy contrast CT. If you have a doubtful cartilage invasion on a standard CT, the current guidelines actually recommend using an MRI to solve the problem, not dual energy CT. Dual energy CT is an advanced problem solving tool mostly utilized in very well equipped tertiary cancer centers. It is not available at most places. It is not routinely used everywhere because these scans generate massive amounts of data that needs a large hospital storage. Extracting these specific iodine maps also require dedicated software, workstations, and extra time from your radiologist. However, as treating radiation oncologist, you must clearly understand this concept. It is a brilliant way to deeply understand the biology of tumor neovascularity and the true physical limitations of our standard anatomical imaging. This slide summarizes the exact recommended dual energy CT criteria for evaluating laryngeal cartilage invasion. See the top row, outlined by the red box, representing a true positive invasion. The protocol dictates that you must first evaluate the lesion on the WA image on the left. If the WA image shows a structural defect, you must then read the corresponding IO image to identify the actual iodine distribution in that exact area. Look at the red arrowheads and the plus sign. When the IO image shows a corresponding area of tumor cartilage invasion as a distinctly red colored area, you can definitely diagnose a positive invasion based on these combined findings. When the IO image does not show a corresponding area of tumor cartilage invasion as a red colored area, tumor invasion can be defined as negative. This red enhancement proves that iodine contrast has actively distributed into the vascular tumor tissue invading the framework and is not just a normal cartilage. Now shift your focus to the bottom row, outlined by the blue box, representing a negative invasion. Look at the WA image here. The tumor marked with the letter T looks highly suspicious and appears to be structurally invading the cartilage. However, you must cross-reference this with the IO image on the right. Look closely at the area indicated by the blue arrowheads and the minus sign. Because the IO image does not show a corresponding red colored area of enhancement inside the cartilage, this tumor invasion must strictly be defined as negative, uninvolved. This confirms the suspicious area is merely normal, non-ossified cartilage, which naturally lacks iodine uptake and not an actual invading tumor. By requiring combined images findings from both WA and IO images rather than relying on structural WA images alone, our diagnostic specificity for cartilage invasion jumps significantly from 70% to 96%. Let us look closely at the actual data behind these imaging protocols. We need to understand exactly why the dual energy CT scan technology is so clinically impactful for our patients. Look at these numbers. When you evaluate cartilage invasion using only standard weightage average images, simply single energy conventional CT scan, the diagnostic specificity is barely 70%. This is a dangerously low number. Think of specificity as our false alarm rate. False alarm rate. Imagine you have 100 patients whose cartilage is completely uninvolved and free of tumor. A standard CT scan alone will correctly identify 70 of these patients as having cartilage uninvolved. But here is the major problem. It sounds a false alarm for the other 30 patients. A standard CT will report cartilage to be involved when it actually is not in these 30 patients. The clinical consequence of this is devastating. Because of those 30 false alarms, 30 patients are falsely upstaged to a T4A. This means they will be sent for total laryngectomy to entirely remove their voice box when a much more conservative organ preservating treatment would have worked perfectly fine. Just think about that. Now look at the right side of the screen. When we do dual energy CT scan and do the combined analysis of both the WA and the iodine overlay images, the diagnostic specificity skyrockets to an impressive 96%. Crucially, this massive improvement comes with absolutely no compromise in sensitivity. The sensitivity remains perfectly stable at 86%. What does these high specificity and unaffected sensitivity mean to you? This is exactly where the combination of weighted average and iodine overlay images changes absolutely everything. If you have 100 patients whose cartilage is completely free, dual energy CT will correctly report cartilage uninvolved in 96 of them and will only raise a false alarm in remaining 4 patients only. So only these 4 patients will be sent for total laryngectomy, in comparison to 30 patients when only a standard CT alone is done. Just think about the clinical impact dual energy CT has. Also, the clinical data shows that using this combined approach significantly improves inter-observer reproducibility. Simply put, different radiologists looking at the exact same scan are much more likely to agree on the final diagnosis. This increased consistency is especially proven for the critical evaluation of thyroid and cricoid cartilage. By strictly relying on this dual parameter evaluation, we can confidently trust our imaging. This ensures we never wrongly deny our patients a chance at safe organ preservation. I want to discuss a very important practical issue in next few slides. Pay attention. We are going to deeply discuss the precise roles of CECT and MRI in staging laryngeal and hypopharyngeal cancers. As oncology residents, you will frequently face this exact clinical dilemma in your practice. You will constantly wonder which imaging modality is the absolute best for your specific patient. You will be asked in exam very often. You must clearly understand that these two scans are not simply interchangeable. Think of the contrast enhanced CT scan as your absolute first line workhorse. Consider it as your initial first choice in general. CECT should be your first answer when examiner asks you which imaging will you do for laryngeal and hypopharyngeal cancers. Think of the MRI as your highly specialized problem-solving tool. You might naturally ask why we do not simply order an MRI for every single patient. After all, an MRI provides much better soft tissue contrast. The answer comes down to pure clinical practicality and patient safety. In the upcoming slides, we will break down exactly when to use each modality. We will establish a clear clinical protocol for modality selection. This specific protocol is absolutely vital when you are planning an organ preservation strategy. It shows a very clear visual comparison between our two main imaging machines. On the left side in blue, you see the contrast enhanced CT scanners. We call the CT scan our clinical workhorse. It is your absolute first line modality for baseline staging in almost every single patient. On the right side in red, you see the MRI scanner. We call the MRI our dedicated problem solver. It is a highly specialized tool that you will use to solve specific borderline clinical dilemmas. You must clearly understand that these two machines do not do exact same job. They are not simply interchangeable. Let us now understand why we do not simply use the MRI for every single patient. There is a major problem with doing MRI routinely for every patient with these tumors. We can call it a 30 minutes trap. An entire neck MRI takes approximately 30 minutes to complete. During this entire time, the patient must lie perfectly still. They must absolutely refrain from swallowing or coughing. Now imagine a typical patient presenting with a bulky laryngeal or hypopharyngeal cancer. These patients very often suffer from severe airway compromise. They experience labored breathing and excessive pooling of saliva. They may have pain. They may have pain during swallowing during these 30 minutes of scan. Expecting them to lie completely still without swallowing can be very difficult. And the problem is any small movement or swallowing action completely degrades the MRI images. We call it motion artifacts. These severe motion artifacts make the scan clinically useless. Also, the cost of MRI is almost double of CECT. Also, the availability of MRI is sometimes an issue, especially if it is being done at government hospitals where there is waiting list. Also, you need more training to read MRI than CECT scans. When you consider all these issues, the conclusion becomes very clear. This is exactly why an MRI absolutely fails as a universal first-line staging tool. See, when you are asked in exam which imaging will you do for laryngeal or hypopharyngeal cancer, you should say CECT, not MRI. And these are the 5 points you should defend your answer. But to be very honest, most oncologists who are working in private or corporate hospitals where cost and availability is not an issue, they go for MRI straight. This slide perfectly summarizes why we use a contrast enhanced CT scan first. As I said, this is our first line baseline imaging modality. There are several very practical reasons for this. First, a standard CT scan is extremely fast. Because it takes only a few seconds to perform, it is highly resistant to swallowing or breathing artifacts. This is a massive advantage when scanning patients with bulky tumors and compromised airways. Second, it is highly cost effective and widely available in almost every center today. Now look at the 3 main anatomical targets highlighted on the right side of your screen. Number one is the primary tumor. A CT scan provides excellent spatial resolution. It gives us a highly accurate and comprehensive overall map of the disease burden. Number two is the cartilage involvement. A properly done standard CT scan beautifully outlines the baseline structural framework of the laryngeal cartilages. Number three is the lymph nodes. A CT scan is highly accurate for mapping regional metastatic neck nodes. Because of these combined clinical benefits, the contrast enhanced CT remains the undisputed modality of choice for initial evaluation. Even though our contrast enhanced CT is a fantastic tool, it is not perfect. It has two major clinical blind spots that you must always keep in mind. We clinically refer to these as the tissue trap and bone trap. Let us start with the left side of this slide. This represents the tissue trap. A standard CT scan relies almost entirely on identifying soft tissue thickening, but it fundamentally struggles to tell the difference between actual cancer cells and the surrounding reactive inflammation. Because of this edema, a CT scan will very often overestimate the true size of the malignancy. Now see bone trap. You must understand that the normal ossification of laryngeal cartilage is highly variable among different patients. Some areas ossify completely, while others remain as non-ossified hyaline cartilage. See thyroid cartilage for these two patients. Here, cartilage is unossified, and here it is ossified. Because the densities are so similar, a CT scan can easily miss very early cartilage invasion hidden within this normal variance. These two specific traps are exactly where our standard baseline scan fails. We just discussed the two major clinical blind spots of a standard CT scan. You will frequently face cases where you cannot tell the difference between reactive edema and an actual tumor. You will also see cases where irregular cartilage ossification hides early true invasion. When you face this exact clinical dilemma, you cannot simply guess. This is the precise clinical moment you ask for an MRI. You must now escalate your diagnostic approach. You are no longer just doing basic anatomical mapping. You are now using a highly specialized tool for definitive problem solving. Knowing exactly when to make this transition is the absolute key to successful organ preservation. This is a highly practical example of how to read an MRI to confirm or rule out cartilage invasion. As we discussed earlier, an MRI is our definitive problem solver for bulky disease, especially when the cartilage is not ossified or when a CT scan does not show frank erosion or lysis. To make an accurate diagnosis, we must carefully compare the T2 weightage images with the post-contrast T1 fat saturated images. See the top left images. This patient has bulky disease involving the supraglottis. Here we can see a signal along the left lamina of the thyroid cartilage. Look at the left thyroid lamina pointed out by the red arrow. Notice that the contrast enhancement inside the cartilage is exactly the same as the primary tumor itself in fat saturated sequence. Can you notice this? When the contrast enhancement perfectly matches the tumor on these post-contrast images, it definitely confirms positive cartilaginous invasion. Now see this patient. You can see enhancement in cartilage here also. In this enhancement, because of tumor involving cartilage, is this enhancement because of tumor involving cartilage or peritumoral inflammation? How do we differentiate them? Look closely at the signal inside the cartilage. In this case, the cartilage shows a hyper signal intensity that is actually much brighter or more prominent than the tumor signal itself. Furthermore, the enhancement within the cartilage is also more prominent than the rest of the laryngeal tumor mass. This disproportionately bright signal indicates reactive peritumoral inflammation, not an active malignancy. This is how MRI helps in differentiating between true cartilage invasion and peritumoral inflammation. CT scan will not be able to do this. An MRI beautifully distinguishes the true tumor margin from the surrounding reactive edema. It completely solves the CT inflammation blind spot we just discussed. Now I want to show you some numbers for MRI with regard to its superior contrast resolution. An MRI provides an incredible 89 to 96% sensitivity for detecting early cartilage erosion. Such an excellent sensitivity. Also, MRI provides exceptional visibility into hidden and complex anatomical structures. It allows us to perfectly assess the deep pre-epiglottic and paraglottic spaces. This level of deep soft tissue detail is simply impossible to achieve with a standard baseline CT scan. Let us bring all of these imaging concepts together into one clear summary. This table perfectly breaks down the fundamental clinical differences between our two modalities. Let us start by reviewing the column on the left for contrast enhanced CT. This is always your primary baseline tool for initial mapping and staging. Because the scan only takes a few seconds, it is highly comfortable for patients with airway distress. However, you must always remember its major diagnostic limitations. The tumor boundaries on a standard CT scan can be quite ambiguous. It fundamentally struggles to differentiate actual cancer cells from the surrounding peritumoral inflammation. It also gives highly variable results when evaluating regularly ossified cartilage. Now see MRI column on the right side of the table. This is your specialized problem solver image modality. Because an MRI takes 30 minutes, it is highly sensitive to any patient movement or swallowing. However, the soft tissue clarity it provides is absolutely precise. It brilliantly distinguishes the true active tumor margin from simple surrounding edema. Furthermore, it provides a definitive evaluation of the deep paraglottic and pre-epiglottic space. It also has an incredible 89 to 96% sensitivity for detecting early cartilage erosion. You must master this specific metrics to make the right staging decision for your patients. Let us summarize what a resident should do when he gets a patient with laryngeal or hypopharyngeal cancer and asked to choose local imaging for this patient. This algorithm perfectly summarizes exactly how you should approach modality selection as an oncology resident. You must always start your baseline staging with a high quality contrast enhanced CT scan. Once you have that baseline map, you look at your clinical plan. Are you aiming for an organ preservation strategy such as partial laryngectomy or transoral laser resection? If you are, you must ask yourself one highly critical question before moving forward. Does this standard CT scan you did leave you with any doubts regarding early cartilage invasion or the exact soft tissue borders? If the answer is no, and the CT is completely unambiguous, you may safely proceed with your surgical planning. But if the answer is yes, you cannot simply guess. You must actively escalate to an MRI now. You must use the MRI to definitely resolve those borderline margins and meticulously assess the deep space cartilage parameters before you ever take the patient into the operating room. So with this, we have completed a detailed discussion about cross-sectional local imaging for laryngeal and hypopharyngeal cancers. So guys, we are done with the detailed discussion on CT and MRI. What will you choose? When will you choose one over the other? Now it is time to put all of that theory into actual clinical practice. In my next slides, we are going to look at actual abnormal patient scans. We will go through a large series of real clinical cases together. We will evaluate them very systematically, subsite by subsite. You must train your eyes to quickly identify the primary mass. You must also learn to actively look for the subtle routes of submucosal spread that we discussed earlier. Let us dive straight into our first clinical case. Let us start with the supraglottic cancer. This is a very early lesion. Look at the axial CT scan labeled A on the far left. Now look at the coronal CT scan labeled C on the far right. Follow the straight white arrows in both of these images. They point to a distinctly abnormal enhancing mass. This mass is located entirely within the left false vocal cord. Now see the axial CT scan labeled B in the middle. This image is taken further down the patient's airway. It is taken at the exact level of glottis. Look very closely at the true vocal cords here. They appear completely normal, clean and symmetric. There is absolutely no tumor extending down into this subglottic region. So what is the clinical staging of this patient with epicenter in the false vocal cord? By strict TNM definition, a tumor that is confined to just one single subsite of the supraglottis is classified as a T1 lesion. In this specific patient, the disease is completely isolated to the left false vocal cord. Because the true vocal cords are completely free of disease, we can safely assume their mobility will be normal. Of course, you will correlate all these findings with endoscopy to see if there is extension of mucosal disease beyond false vocal cord. You will also see the mobility of true vocal cords. You must always confirm that the glottis is completely clear before confidently assigning this early stage. Look at this next patient. This is a more advanced presentation of supraglottic cancer. We have an axial, a coronal and a sagittal CT image labeled A, B and C. Follow the straight white arrows across these first three images. They point to a large, proliferative and highly irregular tumor mass. This mass is extensively involving the right vallecula as well as the right side of both the suprahyoid and infrahyoid epiglottis. It is also extending medially to involve the median glossoepiglottic fold. Now I want you to focus very closely on the sagittal CT image labeled C in the middle left corner. Look for this small blue arrowhead. This is the most critical diagnostic finding on this entire scan. It clearly shows that the tumor is aggressively invading directly into the fat of the pre-epiglottic space. Why is this specific finding so important for a clinical practice? By strict TNM staging rules, the moment a supraglottis tumor invades the pre-epiglottic space, it is automatically upstaged to a T3 stage. This applies even if the patient has completely normal vocal cord mobility. Finally, look at the sagittal image labeled D on the bottom right. This is a paramedian cut taken slightly to the left, away from the main tumor bulk. Follow the shouldered arrow to see a perfectly normal, thin and uninvolved epiglottis on the left side. Comparing the diseased site to the healthy contralateral side is an excellent way to train your eyes to recognize these precise tissue boundaries. And not to forget, you must be doing direct laryngoscopic examination for each and every patient I am showing you to correlate with cross-sectional imaging. Let us examine another very interesting case of supraglottis cancer. This is another classic T3 tumor arising from the false vocal cord. Let us start with axial CT scan labeled A on the top left. Look at the areas pointed out by the red arrows. There is a distinct right side supraglottic mass. This mass is actively invading both the pre-epiglottic fat and the right paraglottic fat. Now look at the yellow arrow on the opposite side. It points to the completely normal, clean paraglottic fat on the left side. Comparing the diseased side to the healthy side makes this abnormal fat invasion very obvious. You see image labeled B on the top right. Look closely inside the red oval. This clearly shows the tumor extending laterally to involve the right piriform sinus. Finally, look at the bottom row with images C and D. These images are taken lower down in the airway. They show the glottis and the subglottis. These areas are completely clear. There is absolutely no tumor extending down into the true vocal cords or the subglottic space. So why do we stage this patient as a T3 lesion? By strict staging rules, even if the glottis is completely clear and mobile, direct invasion into pre-epiglottic and paraglottic fat automatically upstages the patient to a T3 category. You must actively look for this fat obliteration on every scan you read. Look at another variation of a T3 supraglottic cancer. This tumor also arises from the false vocal cord, but its spread pattern is slightly different. Start with the axial CT scan labeled A on the far left. Follow the red arrow to clearly identify the right-sided supraglottic mass. Now look at the yellow arrows pointing to the anterior and lateral spaces. They show that the tumor has partially effaced the pre-epiglottic fat. It has also distinctly invaded the right paraglottic fat. Notice how the left paraglottic fat remains completely clean and preserved for an easy comparison. Next, look at the bone window image labeled B. This is a very important step when you read CT image of such patients. Despite the extensive fat invasion, there are absolutely no definitive erosive changes in the right thyroid cartilage. Now shift your focus to the images labeled C and D. Image C is an axial cut taken lower down and image D is a coronal reformat. Look at the blue arrows in both of these images. They clearly show the tumor extending inferiorly to involve the right glottis. This is a classic example of transspatial spread. The tumor started in the supraglottis and moved downward into the glottic space. Because this tumor invades the paraglottic and pre-epiglottic fat spaces, it is staged as T3 lesion. Let us move on to an even more advanced stage of supraglottic cancer. This is a classic presentation of a T4A lesion. Let us start with the axial CT scan labeled A on the far left. Follow the red arrow. It points to a large aggressive mass in the right supraglottis. The tumor is clearly invading the right paraglottic fat. Interestingly, it is sparing the pre-epiglottic fat in this specific patient. But now look very closely at the purple arrow on the outer edge of that same image. This is a critical staging finding. You can clearly see soft tissue density physically extending beyond the outer boundary of the thyroid cartilage. This definitely proves that there is extralaryngeal spread. Now look at the bone window image labeled B in the middle. Follow the two yellow arrows. They show extensive and obvious erosive changes completely destroying the thyroid cartilage. Either of these findings, the frank cartilage destruction or the extralaryngeal spread, automatically makes this a T4A disease. Finally, let us look at the image labeled C on the far right. In this patient, there is no clear evidence that the tumor extends down into the glottis or subglottis. However, look at the blue arrow on the lower left side of that image. It points to a clearly enlarged palpable lymph node in the neck. This scan perfectly demonstrates why we must carefully evaluate both the soft tissues and the bone window. You cannot afford to miss these subtle signs of cartilage destruction. Let us move on to our next subsite of larynx and examine a case of glottic cancer. This is a classic presentation of an advanced glottic tumor with thyroid cartilage erosion. Let us start with the axial and coronal CT images labeled A and B. Follow the straight white arrows in both of these images. They point to a large proliferative lesion involving the true vocal cords bilaterally. Notice how this extensive tumor bulk has caused almost complete obliteration of the patient's airway. This severe life-threatening airway compromise is exactly why this patient required an emergency tracheostomy. You can see the tracheostomy tube here. Now listen to me very carefully and see very closely at the axial image labeled A again. Focus on the area indicated by the shouldered arrow. This shows the mass directly invading the inner cortex of the right thyroid lamina. By strict TNM staging rules, tumor invasion that is limited only to the inner cortex classifies this as a T3 lesion, not T4A lesion. Only if it had penetrated through the outer cortex, we would upstage it to a T4. Finally, let us look at the image labeled C on the far right. There are absolutely no suspicious or enlarged neck nodes visible. This lack of nodal metastasis is very typical for glottic cancer. Unlike the supraglottis, the true vocal cords have very sparse lymphatic drainage. Let us look at a much more advanced case of glottic cancer. This is a very clear example of a T4A glottic tumor. You can see a large and destructive mass starting in the right glottis. Notice how this tumor shows obvious transglottic spread. It is clearly spreading to involve both the anterior commissure and the posterior commissure. This kind of extensive spread along the mucosa is very concerning. But now, I want you to focus directly on the thyroid cartilage. You can clearly see that the tumor has grown completely through it. This is what we call transmural extension. The tumor has breached both the inner and outer layers of the cartilage. Because of this frank cartilage penetration, we must stage this patient as T4A lesion. You cannot afford to miss this deep invasion on your daily scans. Now think about what you would see in the clinic for this patient. When this specific patient underwent a clinical laryngoscopy, the right vocal cord was completely fixed. It was not moving at all. This functional fixation directly matches the deep tissue invasion we see here on the scan. This is exactly why you must always correlate your clinical examination with your imaging findings. Let us continue looking at advanced glottic cancer with another T4A case. These are the 4 images of a patient. Let us start with the axial soft tissue scan labeled A on the top left. The yellow arrow points to a distinct mass arising in the right glottis. Now follow the blue arrow on that exact same image. It shows the tumor spreading directly into the anterior commissure. Next, I want you to look at the corresponding bone window image labeled B on the top right. Follow the red arrows carefully. You can clearly see that the tumor has eroded completely through the thyroid cartilage. This transmural extension automatically makes this a T4A disease. Now shift your focus to the bottom row to evaluate the upward spread of this tumor. Look at the soft tissue image labeled C on the bottom left. Inside the red oval, you can clearly see an asymmetric soft tissue density. This proves the tumor has grown upward into the supraglottis and aggressively invaded the right paraglottic fat. Finally, look at the bone window image labeled D on the bottom right. The purple arrow confirms further erosions of the right thyroid cartilage at this higher level. This case perfectly demonstrates how glottic tumors can spread both outwards through the cartilage and upward into the paraglottic space. You must always check these multiple planes. Let us evaluate another important scan showing advanced glottic cancer. Focus your attention on the area marked with black asterisks. This represents a large and abnormally enhancing tumor mass. It is clearly involving the right true vocal cord. Now I want you to follow the straight white arrow. Look very closely at the cartilage right there. You can see the tumor is directly invading the right thyroid cartilage. This is a critical staging finding that you must actively search for. Next, shift your focus backward to the small yellow arrow. It points directly to the right arytenoid cartilage. Notice how the tumor mass is completely encasing it. These are definitive signs of an advanced and aggressive disease process. Finding this level of gross cartilage involvement significantly changes your clinical staging. It immediately moves the patient away from early stage disease. This will directly dictate whether your patient is a candidate for organ preservation or requires radical surgery. You must carefully trace the borders of every single cartilage to catch these exact features. Let us now look at a visual gallery of images of 4 different patients with advanced glottic cancer. These images perfectly illustrate the clinical progression from a T3 to a T4B stage. Let us start with the first 2 images on the left. Both of these represent T3 glottic tumor. In these specific cases, the disease is still technically confined within the larynx. However, they show very aggressive local features. You will typically see deep invasion into the paraglottic space, or you might see focal erosion that is limited strictly to the inner cortex of the thyroid cartilage. As long as the outer cortex remains completely intact, the tumor remains as a T3. Now shift your focus to the third image labeled T4A. Here, the anatomical boundary has been completely breached. The tumor has destroyed the outer cortex of the cartilage. It is now frankly invading the extralaryngeal soft tissue of the neck. This transmural spread is the classic defining hallmark of a T4 disease. Finally, look at the last image on the far right. This is a T4B lesion. This represents very advanced and unresectable local disease. In this stage, the tumor has grown far beyond the laryngeal framework. It is actively encasing the carotid artery. It may also be directly invading the prevertebral fascia at the back of the airway. This is a critical staging threshold that dictates a complete shift in our oncological treatment intent. You must carefully evaluate these exact tissue boundaries on every single scan you read. Let us now move to the third laryngeal subsite, subglottis. Primary subglottic cancers are actually quite rare. Unfortunately, they are often clinically silent and tend to present late with a very poor prognosis. Here we are directly comparing an early stage lesion with a very advanced lesion. Start with the image on the left, representing a clinical T1 cancer. You can see a smooth, well-defined, enhancing mass on the right side. Follow the black asterisk to see it reaching anteriorly just below the anterior commissure. This is a subtle finding that requires careful evaluation of your axial cuts. Now shift your focus to the image on the right. This represents a highly aggressive T4A advanced lesion. Notice the large circumferential mass completely taking over the subglottic airway. Follow the curved black elbow arrows. They show frank destruction of both cricoid and thyroid cartilages. Finally, look at the thin white arrows pointing outward. They clearly demonstrate the tumor spreading into the extralaryngeal soft tissue of the neck. Seeing this level of cricoid cartilage destruction and outside spread completely changes our surgical approach. This is another clear example of subglottic disease. This scan shows how a primary laryngeal mass can extend downwards into the subglottis. Start with the axial CT image labeled A on the left. Follow the straight white arrow. It points to an abnormal soft tissue mass and mucosal thickening. You can clearly see this abnormal tissue located right between the airway and the cricoid cartilage. Any abnormal tissue in this specific anatomical space must be actively searched for. Now look at the coronal CT image labeled B on the right. Follow the straight white arrow in this plane. This coronal view perfectly demonstrates the tumor extending inferiorly. It is actively growing below the level of the true vocal cords, deep into the subglottic region. Identifying this downward spread is absolutely critical for your accurate clinical staging. This specific finding will completely change your surgical planning and your radiation field design. Let us move on to a very challenging clinical entity. This is a classic example of a transglottic cancer. By definition, a transglottic tumor crosses the laryngeal ventricle. It includes both the supraglottis and the glottis, and often reaches the subglottis. Look at this image. The coronal plane is absolutely the best way to evaluate this vertical spread. Follow the thin white arrows on the right side of the patient's airway. They show a large aggressive mass spreading extensively along the right paraglottic space. The tumor is completely filling this vertical fat corridor. Now look at the thick white arrow on the opposite side. It points to the completely normal, clean left paraglottic fat space. You can easily see the striking difference between the diseased side and the healthy side. Why is this exact finding so critical for our treatment planning? Extensive transglottic spread through the paraglottic space means a very high tumor volume. This massive volume of disease typically rules out conservative organ preservation. It usually precludes primary radiation or a partial laryngectomy. These patients almost always require a complete total laryngectomy. This is another patient having a transglottic cancer. This image perfectly demonstrates how these tumors spread outward. Look closely at the area marked with the black asterisk. This shows the tumor deeply invading the pre-epiglottic space. Now look at the white asterisk. This shows the tumor aggressively filling the right paraglottic space. But the most critical finding is on the outer edge. Follow the small white arrow on the right side of the image. They show the tumor breaking completely out of the larynx. This is clear extralaryngeal extension running along the outside of the right thyroid lamina. Now, look right next to those white arrows. Follow the black arrow. It shows this tumor mass directly abutting the right carotid artery. Finding tumor touching the carotid artery is a very serious clinical situation. It immediately raises the question of whether this tumor is safely resectable. You must trace the carotid artery carefully on every single slice. Look at one more view of a transglottic cancer. This is sagittal CT image. This specific cut is extremely helpful for evaluating anterior tumor spread. Remember that a transglottic tumor crosses the laryngeal ventricles and involves multiple vertical subsides. Now follow the curved white arrow in the center of the image. It points directly to the lower portion of the pre-epiglottic space. You can clearly see the aggressive tumor tissue actively invading this fat-filled space. This is exactly why we always request sagittal reformats. A sagittal plane gives you the absolute best visualization of the entire pre-epiglottic space from top to bottom. Finding tumor deeply invading this space confirms a highly advanced and bulky disease stage. You must routinely check your sagittal cuts to map this specific pathway. This is a very aggressive case of transglottic cancer. This is a classic presentation of a T4A transglottic tumor. We will start with the axial and coronal CT images labeled A and C. Follow the straight white arrows in both of these images. They point to a large exophytic mass on the right side. This mass clearly involves both the right aryepiglottic fold and the right true vocal cord. It is aggressively filling the entire right paraglottic space. Now, I want you to focus very closely on the axial image labeled B. Look at the area pointed out by the small yellow arrow. You can clearly see that the tumor is breaking completely out of the laryngeal framework. This definitive extralaryngeal spread is exactly what makes this a T4A disease. Finally, look at the axial image labeled D on the bottom left. Follow the shouldered arrow. It points to an enlarged necrotic lymph node in the right level 2 neck station. Finding a metastatic necrotic node like this significantly worsens the patient's overall survival. It perfectly highlights why we must systematically evaluate all neck nodal stations after assessing the primary tumor. Let us move on to another case of transglottic cancer. This is a very clear example of a T4A transglottic tumor. We have 3 axial CT images labeled A, B and C. Follow the straight white arrows in these images. They point to a large and enhancing primary mass. The tumor actively involves the true vocal cords bilaterally. It also extends upward to involve the left false vocal cord. You can clearly see that it is filling the left paraglottic space. Now look at the right side of the airway. The right arytenoid cartilage appears heavily sclerosed. This is a very suspicious sign for tuber involvement. But the most critical staging finding is located anteriorly. Follow these shouldered arrows pointing to the front of the airway. There is gross destruction of the thyroid cartilage. This destruction is much more prominent on the left side. You can even see subtle tumor tissue breaking completely outside the larynx. This frank cartilage destruction and extralaryngeal spread definitely makes this a T4A lesion. You have to be very careful to catch these subtle outward extensions on your daily scans. Let us look at how an MRI evaluates a transglottic cancer. Look at the multi-panel slide currently on your screen. This patient has a very large tumor involving both the supraglottis and glottis. We are looking at multiple different MRI sequences to fully characterize this massive lesion. Start with the top row, looking at images A, B and C. These are your standard axial cuts. Follow the white arrows in each box. The tumor is iso-intense on the T1 weighted image labeled A. It shows intermediate signal intensity on the T2 weightage image labeled B. And it shows very clear heterogeneous enhancement on the post-contrast image labeled C. Now look at the images labeled D and E. These give us our necessary coronal and sagittal views. They clearly map the extensive vertical spread of the tumor across the different laryngeal subsides. Finally, shift your focus to the bottom right. Look at the images labeled F and G. These represents the diffusion weighted imaging and ADC map. This is a functional assessment of the tissue. The bright signal on the diffusion image combined with the corresponding dark signal on the ADC map proves that this mass has restricted diffusion. This confirms highly cellular and aggressive tumor tissue. This specific case perfectly highlights why an MRI is an incredible problem-solving tool in your clinical arsenal. Let us move on to a new anatomical region, hypopharyngeal cancers. Look at the MRI scans currently on your screen. This is a patient with a squamous cell carcinoma of the right piriform sinus. Let us start with the T2 weighted axial image labeled A on the top left. Follow the straight white arrow. It shows the cancer deeply invading the paraglottic space. Now look at the white arrowhead on that exact same image. It shows the tumor directly invading the pharyngeal constrictor muscle. Follow the curved arrow to see the tumor extending along this muscle. It reaches the posterolateral margin of the thyroid cartilage. This represents very aggressive local spread. Look closely at black arrowheads on the far left edge of image A. They point to metastatic lymph nodes in level 3. Now shift your focus to images B and C. These are plain and contrast enhanced T1 weighted images at the same level. You can clearly see areas of central necrosis within the primary tumor. Notice how those level 3 lymph nodes enhance abnormally after contrast. This abnormal enhancement confirms metastatic nodal disease. Now let us look at those lower images labeled D and E. These images help us map the inferior extent of the tumor. Image D is taken at the exact level of the piriform sinus apex. The arrowhead shows the tumor growing into the paraglottic space at the level of the true vocal cords. Image E is taken even lower down at the mid post-cricoid region. Follow the straight arrow in image E. It proves the tumor has spread well below the apex of the piriform sinus. Finally, follow the arrowheads in image E. They show the tumor actively invading the inferior cornu of thyroid cartilage. It is spreading right between the cricoid and thyroid cartilages. This deep inferior spread completely changes your surgical planning. Let us examine another case of hypopharyngeal cancer. This patient has a proliferative cancer arising in the left piriform sinus. We have a combination of contrast enhanced CT and PET-CT images. Let us start with the anatomical imaging on the left. Look at the axial and coronal CT images labeled A and B. Follow the straight white arrows on both images. They point directly to a bulky enhancing mass filling the left piriform sinus. Now look at the axial CT image labeled C on the bottom left. Follow the shouldered arrows on both sides of the neck. They point to enlarged abnormal lymph nodes in the bilateral level 2 neck station. Bilateral nodal involvement completely changes our treatment approach. Next, let us look at the functional imaging on the right side of your screen. These are the corresponding PET-CT images labeled D and E. Look at the bright yellow and orange areas. Image D perfectly confirms intense radiotracer uptake exactly at the site of the primary tumor. Image E confirms significant metabolic activity in those bilateral level 2 neck nodes. This functional scan definitely proves that these nodes are metastatic. These images highlight why PET-CT is highly recommended for advanced locoregional disease. It accurately maps the total burden of the disease before we start any aggressive treatment. Let us look at a very unique and highly challenging case of piriform sinus cancer. Look at the multiple CT scan currently on your screen. This specific patient presented with a clinical history of hoarseness that lasted for over a year. During that year, they underwent multiple clinical endoscopic examinations. However, every single endoscopy showed absolutely no visible tumor. Why did the endoscope completely miss this advanced cancer? Because this entire tumor was growing completely submucosally. It was hiding deep beneath the normal looking surface tissue. Let us start with the axial images labeled A and B at the top. You can clearly see a large infiltrating mass originating in the right piriform sinus. Notice how it aggressively invades the paraglottic space and the post-cricoid region. Now shift your focus downward to the images labeled C and E. Follow the small arrowheads in the image C. They show the tumor breaking completely out of the larynx. It is directly invading the upper pole of the right thyroid gland. In image E, you can clearly see the tumor invading the muscular wall of the cervical esophagus. Finally, look at the bone window images labeled F and G on the bottom left. The arrow points to obvious and chronic erosion of both thyroid and cricoid cartilage. This case perfectly illustrates a critical clinical lesson. If your patient has persistent, severe symptoms, but a completely normal mucosal endoscopy, you must strongly suspect a deep submucosal lesion. You must heavily rely on your cross-sectional imaging to find the hidden disease. Let us evaluate another important case of piriform sinus cancer. Look at the 3 CT images currently on your screen. This case perfectly highlights how even a small primary tumor can be highly aggressive. Start by looking at the axial CT scan labeled A on the top left. Follow the white arrow closely. They show a low volume cancer arising in the right piriform sinus. But notice how it actively invades the superior laryngeal neurovascular bundle. It is directly spreading completely outside the laryngeal framework. This is a critical anatomical pathway for extralaryngeal spread that you must actively trace. Now shift your focus to the image labeled B on the top right. The white arrows here confirm that exact same spread pattern along the neurovascular bundle. You can also see an associated metastatic lymph node developing right next to it. Finally, look at the image labeled C on the bottom left. Follow the straight black arrow in the center. It points to definitive submucosal spread. The tumor is reaching all the way to the junction of hypopharyngeal and oropharyngeal posterior wall. Now look at the small black arrowheads on the far left edge of that same image. They point to a positive level 2 lymph node. Notice the multiple peripheral metastatic deposits clearly visible within it. This case perfectly demonstrates why you can never underestimate a piriform sinus lesion, no matter how small it initially appears. Look at this patient with piriform sinus cancer. Look at the two CT images currently on your screen. This patient has a tumor involving both the piriform sinus and the aryepiglottic fold. Notice how this tumor appears almost entirely exophytic or outward growing on the surface. But you must always look deeper. Look at the image on the left. Follow the small arrowhead. It shows the tumor actively spreading along the superior laryngeal neurovascular bundle. It is breaking completely outside the boundaries of the larynx. Now follow the solid white arrow on that same image. It points to an associated level 3 metastatic lymph node. Notice how this entire lymph node has been completely replaced by the tumor. Next, shift your focus to the image on the right labeled E. Even though this tumor looks relatively lobulated on the surface, look closely at the area marked by the arrow. It shows probable early invasion directly into the thyroid lamina. This case perfectly illustrates that a benign surface appearance can be highly deceiving. You must evaluate the deep margins and neurovascular bundles on every single scan. Let us examine one final highly aggressive case of piriform sinus cancer. Look at the 3 CT scans currently on your screen. These images demonstrate severe and advanced extralaryngeal spread. Focus your attention on the images labeled F and G on the left side. Follow the small black arrows. They show the tumor growing directly through the thyrohyoid membrane. It is actively tracking along the superior laryngeal neurovascular bundle. This is a classic and dangerous pathway for these tumors to escape the larynx. Now look very closely at the image G on the bottom left. Notice how this escaping tumor has completely encased the carotid artery. This is a devastating clinical finding that immediately makes the tumor unresectable. Finally, shift your focus to the image labeled H on the right. Follow the black arrow in this specific slide. It shows that this outward spread is directly associated with metastatic lymph nodes. These nodes are developing along the exact same neurovascular bundle. You must actively trace this entire neurovascular pathway to catch these aggressive extensions. Let us now move to another anatomical subsite of the hypopharynx. We are now evaluating a patient with a post-cricoid cancer. Let us start with the axial CT scan labeled A on the far left. Follow the straight white arrow carefully. It points directly to an enhancing tumor mass. This mass is completely taking over the post-cricoid region. Now shift your focus to the middle image labeled B. This is a sagittal reconstruction of the exact same patient. Follow the straight white arrow again. The sagittal plane is absolutely critical here. It gives us a very clear picture of how far the tumor extends vertically. You can perfectly map its relationship to the posterior wall of the airway. Finally, look at the axial CT image labeled C on the right. Follow the shouldered white arrows. It points to an enlarged and abnormal lymph node in the right level 2 station. Finding regional nodal metastasis immediately escalates your clinical staging. You must actively search for these nodes when evaluating any hypopharyngeal primary. This is an interesting case of post-cricoid cancer. Look at the multiple CT scans currently on your screen. This patient has an infiltrative tumor that starts just below the apex of the piriform sinus. Follow the white arrow carefully from image A down through D. You are actively tracing the primary tumor downward along the posterior wall of the post-cricoid region. In image D, you can see the tumor reaching the uppermost portion of the cervical esophagus. Because of this deep inferior spread, the patient required a partial upper esophagectomy to clear the disease. Now, I want you to shift your focus to the image E on the far right. Follow the white arrows pointing to the lymph nodes. This patient has bilateral metastatic nodes in level 3 and 5B. However, this specific pattern of nodal spread is very unusual for this particular primary tumor. Also notice the multiple areas of abnormal submucosal enhancement scattered throughout the hypopharynx in that image. This finding brings up the critical oncologic concept of field cancerization. Because of chronic tobacco and alcohol exposure, the entire mucosal lining is at high risk for multiple tumors. Those scattered enhancing areas actually turned out to be separate early infiltrating carcinomas. This case teaches a very vital clinical lesson. If you see a pattern of lymph node metastasis that does not match your known primary tumor, you cannot ignore it. You must actively search for a hidden second primary cancer. This is another advanced case of post-cricoid cancer. This time, we are utilizing an MRI to precisely map the deep soft tissue extent. Look at the images currently on your screen. This patient has a very bulky tumor arising primarily in the post-cricoid region. Start by looking at the sagittal image on the far left. Follow the white arrows pointing downward. You can clearly see this massive tumor extending from the lower hypopharynx all the way down to the inlet of cervical esophagus. This deep inferior spread is exactly why MRI is so incredibly helpful for surgical planning. Now shift your focus to the 4 axial images on the right side labeled C through F. These cross sections precisely map how deep tumor penetrates as we move lower into the neck. In images C and D, you can see the tumor completely filling the post-cricoid space. It actively crosses the midline and infiltrates the muscular wall of the airway. Now look very closely at image E on the bottom left. Follow the small white arrows. They show the tumor breaking out and directly infiltrating the left thyroid lobe. Finally, look at the image F on the bottom right. Follow the small white arrowhead. It points to clear, definitive invasion of the common wall between the trachea and the esophagus. This frank tracheal involvement is a very severe oncologic finding. This extensive spread completely changes the surgical approach and the reconstructive plan. It perfectly highlights why you must trace every single slice downward well into the cervical esophagus. Let us look at another anatomical subsite of hypopharynx. This is the patient with posterior pharyngeal wall cancer. We are evaluating a contrast-enhanced T1 weighted sagittal MRI. The sagittal plane is excellent for evaluating the vertical length of these posterior tumors. Follow the two straight black arrows. They show the primary tumor growing actively along the posterior wall of the hypopharynx. Now look at the downward spread on this lesion. Follow the solid white arrowhead. It shows the tumor extending inferiorly into the post-cricoid region. It reaches all the way down to the lower margin of the cricoid cartilage. This specific anatomical level is very important because it marks the esophageal inlet. Next, look closely at the area pointed out by the curved white arrow. This represents the proximal cervical esophagus. You can clearly see that it has a completely normal and healthy appearance, confirming that the esophagus is entirely free of disease is absolutely critical for our surgical colleagues. It dictates whether a standard pharyngeal reconstruction is possible without needing to remove the esophagus. Let us now explore how an MRI serves as a vital problem-solving tool. Look at the comparative slide currently on your screen. This slide actually shows scans from two entirely different patients. Both are 69-year-old men presenting with hypopharyngeal cancer. In both cases, we are trying to determine if the tumor has deeply invaded the thyroid cartilage. Let us start with the column of images on the left side of your screen. This represents a true negative case for our first patient. Look at the top image labeled A, which is a standard CT scan. The tumor and the adjacent non-ossified cartilage share very similar CT values, making them look exactly the same. This exact scenario makes it almost impossible to rule out invasion using a CT scan alone. Now look at the MRI scan just below it, labeled B and C. On the T2 weighted image, the healthy right thyroid lamina remains distinctly dark compared to the tumor. On the post-contrast image, the cartilage has poor enhancement, unlike the active tumor mass. This clear difference in signal proves that the cartilage is completely free of cancer as confirmed by pathology. Now shift your focus to the column of images on the right side of your screen. This represents a true positive case of cartilage invasion in our second patient. Look at the T2 weightage MRI labeled A. Notice how the signal intensity of the adjacent right thyroid cartilage is dangerously similar to the tumor itself. Next, look at the post-contrast image labeled B. The cartilage is enhancing just as brightly as the primary tumor mass. This matching signal pattern definitely confirms that the tumor has actively invaded the cartilage. The surgical specimen in image C proves this deep invasion perfectly. Whenever your standard CT scan leaves you in doubt, you must rely on an MRI to accurately map these critical tissue borders. Let us examine a significant pitfall when using an MRI. This patient is a 59-year-old man with hypopharyngeal cancer. We are evaluating whether the primary tumor has invaded the left thyroid cartilage. Start by looking at the T2 weightage image labeled A on the top left. You can see the primary tumor mass arising from the left piriform sinus. Now look very closely inside the dotted black circle. The adjacent thyroid cartilage shows an intermediate signal intensity that exactly matches the active tumor. Next, shift your focus to the post-contrast image labeled B. Inside the dotted circle, the cartilage is enhancing just as brightly as the primary tumor mass. Based on these specific MRI signals, you would likely diagnose it as positive cartilage invasion. However, look at the actual surgical specimen labeled C on the bottom left. Look inside the corresponding dotted circle. You can clearly see that the thyroid lamina has absolutely no tumor cell invasion. Why did the MRI falsely suggest cancer? Look at the microscopic pathology slide labeled D on the bottom right. This magnified view shows that the abnormal enhancement was actually caused by an infiltration of lymphocytes, macrophages, and fibrosis. This represents severe reactive inflammation, not an active malignancy. This specific case perfectly illustrates why MRI can have a high rate of false positive. Reactive inflammatory changes near a tumor can perfectly mimic the imaging features of true cartilage invasion. Let us examine another important case comparing CT and MRI. This is a man with a piriform sinus cancer and suspected thyroid cartilage invasion. Start by looking at the contrast enhanced CT image labeled A on the top left. Follow the straight white arrows. They show the primary tumor mass causing focal lysis on the adjacent thyroid cartilage. Now look at the T2 weightage MRI labeled B on the top right. Notice how blurry and indistinct this image is. Because of strong motion artifacts, you cannot reliably evaluate the anatomy or identify tumor invasion here. Next, look at the contrast enhanced T1 weighted MRI labeled C on the bottom left. Follow the small arrowheads. This image shows very extensive contrast enhancement within the thyroid cartilage, which suggests massive widespread invasion. But look closely at the actual surgical specimen labeled D on the bottom right. The arrowhead show only focal infiltration of the tumor into the cartilage. This focal infiltration matches our initial CT finding perfectly. This case perfectly illustrates how a contrast-enhanced MRI can significantly overestimate the true range of tumor cell invasion. Now look at the incredible power of dual energy CT. Look at the four panel slide currently on your screen. This is a 69-year-old man with a hypopharyngeal cancer arising from the left piriform sinus. We are actively evaluating his thyroid cartilage for subtle erosion. Let us start with the image labeled A on the far left. This is the weighted average or WA image, which looks just like a standard CT scan. Follow the small white arrow. It points to an area on the inner cortex of the left thyroid cartilage that strongly mimics focal erosion. If you only had this standard CT view, you would very likely overstage this patient. Now shift your focus to the image labeled B. This is the iodine overlay or IO image. Follow the white arrow to that exact same spot on the cartilage. Notice that there is absolutely no red colored iodine enhancement inside the cartilage. This lack of iodine enhancement definitely proves the active tumor has not penetrated the cartilage. Now look at the actual surgical specimen labeled C. This small black square maps out the true macroscopic border of the tumor. You can clearly see that the cartilage itself is completely intact and tumor-free. The microscopic slide labeled D on the far right confirms this perfectly. This case beautifully illustrates how adding iodine overlay images can eliminate false positive interpretations and potentially save patients from unnecessarily radical surgeries. Let us look at another excellent example utilizing dual energy CT. Look at the 4-panel slide currently on your slide. This is a 70-year-old man with a supraglottic cancer. We are actively evaluating his image for evidence of cartilage lysis. Start with the weighted average labeled A on the far left. Follow the small white arrowhead. They point to the non-ossified right thyroid lamina. On this standard view, the cartilage appears to be completely replaced by the tumor mass, mimicking focal lysis. If you relied only on this single image, you would very likely overstage this patient with a false positive diagnosis. Now shift your focus to the iodine overlay image labeled B. Follow the overheads to exact same location on the thyroid cartilage. Notice that there is absolutely no red colored iodine enhancement in that area. Also, follow the solid white arrow pointing to the right arytenoid cartilage behind the tumor. It also clearly shows zero enhancement. This complete lack of iodine uptake definitely proves the active tumor has not penetrated these cartilages. Now look at the actual surgical specimen labeled C and the microscopic view labeled D. These small black squares maps out the true macroscopic boundary of the tumor. They confirm perfectly that the tumor has not invaded the thyroid or arytenoid cartilages. This case brilliantly proves that dual energy CT can successfully differentiate non-ossified cartilage from an active tumor, preventing false positive interpretation. Let us look at a true positive case of cartilage invasion using dual energy CT. This is a 78-year-old man with glottic cancer. Start with the weighted average image labeled A on the far left. Follow the solid white arrows. It shows the tumor breaking completely through the left thyroid cartilage and spreading into the extralaryngeal soft tissue. Now look at the iodine overlay image labeled B in the middle. Follow the solid white arrow again. The red colored iodine enhancement perfectly and accurately maps this extensive extralaryngeal spread. Next, follow the open black arrow on the image B. It points to a small non-enhanced area in the anterior portion of the cartilage. Look at the surgical specimen labeled C on the far right. It perfectly confirms that this specific non-enhanced spot is completely free of tumor cells. However, this case also highlights a critical technical limitation you must remember. Look at the small white arrowheads on the right side of image A. They point to sclerotic cartilage. Because of how the dual energy algorithm classifies dense bone, this sclerosis cannot be reliably interpreted on the iodine overlay image. If you look at the surgical specimen labeled C, those arrowheads confirm that tumor cells did indeed invade that sclerotic cartilage. This reminds us that heavily calcified or sclerotic areas must always be carefully evaluated on your standard weighted average views. So guys, with this slide I have completed showing you local imaging for laryngeal and hypopharyngeal cancers. Let us move on to the next topic. Let us now proceed for step 6 in the evaluation of laryngeal and hypopharyngeal cancers. This is your comprehensive metastatic workup. Look at the exact anatomy of distant spread. At the time of initial clinical presentation, the estimated incidence of distant metastasis is between 6.5 and 8.5%. Fortunately, this is relatively low baseline risk. However, when these laryngeal and hypopharyngeal cancers do disseminate systemically, they follow a very predictable anatomical pathway. The absolute most important common site for distant spread is the lung. This makes rigorous pulmonary screening a mandatory step in your clinical evaluation. The other rare site for distant metastasis are liver and bone. You must memorize this specific metastatic roadmap. Knowing exactly where the tumor wants to go dictates exactly which imaging tool you must order for your patients. Before we move on to discuss metastatic workup, let me show you a specific anatomical pathway related with subglottic cancers. This is the unique lymphatic drainage of the subglottis. Unlike other laryngeal tumors, subglottic cancers frequently drain inferiorly. The disease drains directly down into the pretracheal and paratracheal lymph node. From there, cancer cells can easily reach the superior mediastinal lymph node. This specific downward pathway creates a dangerous diagnostic blind spot. Therefore, a standard neck CT scan is simply not enough. You must explicitly instruct your radiologist to perform an extended neck and chest CT. The scan must physically extend downward to accurately capture the entire superior mediastinum. This strict protocol modification ensures absolutely no hidden nodal spread is missed in the chest. Let us move on to the metastatic workup. In this step, you must accurately search for distant metastasis. Locally advanced laryngeal and hypopharyngeal cancers have a high propensity for spread to distant organs, especially lungs, followed by liver and bones. You must actively hunt for the systemic spread before planning any radical local treatment. For early gothic cancer with negative nodes, a simple baseline chest X-ray is often sufficient. But for advanced disease or clinically positive neck nodes, you must escalate to a contrast-enhanced chest CT. When will you do PET CT? Not every patient with locally advanced laryngeal and hypopharyngeal cancer require PET CT. There are really no definitive indications, but you should consider doing PET CT in those scenarios where there are very high chances of distant metastasis. So which are those scenarios? These are the 4 indications of PET CT you should remember. 1. When you have multiple cervical nodes. 2. When you have N3 node having clinical extranodal spread. 3. When your single node is located in lower neck, especially in level 4. 4. When you have post-cricoid tumor which is extending into esophagus. Otherwise, doing CT chest is often sufficient. But yes, these days, we, including I myself, do PET CT left and right for all patients with stage 3 and stage 4 laryngeal and hypopharyngeal cancers. But you are asked in exam, you should say these 4 indications. There is an important discrepancy between academic theory and real-world clinical practice. Academic theory here means your board exams and academic vivas. When you are sitting in front of your examiners, you cannot just say you will order a PET scan for every single patient. You must explicitly state the precise indications to justify the scan. You must confidently enumerate those 4 specific high-risk indications we just learned. Multiple cervical nodes, N3 node, single node in level 4 and post-cricoid tumor extending into esophagus. But what is the actual reality of a modern multidisciplinary oncology clinic? In practice, the clinical landscape are shifting. Today, most oncologists are ordering a PET scan. They aggressively order it left and right for all stage 3 and stage 4 laryngeal hypopharyngeal cancers. They do this to ensure absolutely no distant metastasis is missed before committing to grueling radical treatment. So what should you answer when you are asked when will you do PET scan for your patient? To be safe logically, you should mention these 4 indications. But be ready to be countered by the examiner who is working in a private corporate hospital and doing PET-CT in all patients. You should not argue. Why do we so meticulously hunt for distant metastasis? Finding systemic metastasis radically alters your entire treatment plan. In this favorable scenario of M0 stage, that means when there are no distant metastases, you can safely proceed with your curative treatment. You can confidently confirm your radical surgeries or radical chemoradiation. But if you have distant metastasis present, this finding completely precludes any curative surgical attempts or radical chemoradiation. Performing a radical morbid surgery on an M1 patient is simply against the principle of most oncology. It subjects the patient to immense surgical trauma for absolutely no survival benefit. Instead, your entire management paradigm must immediately shift. You must now focus strictly on palliative therapy. If the patient has a very poor performance status, you must shift to best supportive care. This is exactly why you must definitely establish the M stage before you ever pick up a scalpel or radiation. This table shows how a patient's specific clinical risk profile will guide you to choose exact imaging arsenal for M staging. Consider pure early glottic cancer with a clinically negative neck. These lesions have a very low risk of systemic spread. For lesions like T1 and T2 glottic cancer, you actually don't need to look for distant metastasis and hence should avoid doing any imaging for distant metastasis. For early supraglottic cancer patient, a simple baseline chest X-ray is completely sufficient. Now look at the second row, focusing on subglottic cancer. These specific tumors have unique inferior lymphatic drainage pathways. Therefore, you must order an extended neck and chest CT. This ensures you do not miss any hidden nodal spread dropping down into the chest. Shift your focus to third row. This is your most common clinical scenario. You will see advanced cancer presenting with locally advanced cancer, clinically node positive cancers, heavy smokers. These patients carry a high risk of lung metastasis or a synchronous bronchogenic primary carcinoma. Here, a contrast enhanced chest CT is absolutely mandatory. Finally, look at the bottom row. This represents your highest risk patient. These include patients who have multiple cervical nodes, single but N3 node, single but level 4 node, and post-cricoid tumor which is extending into esophagus. These patients can be offered PET-CT. These patients have the absolute highest probability of distant metastasis. This targeted risk-based approach prevents dangerous understaging while avoiding unnecessary and expensive scans. We must discuss a very specific biological reality for these patients. Laryngeal and hypopharyngeal cancer are almost exclusively driven by heavy tobacco and alcohol exposure. This chronic exposure creates a very dangerous dual clinical threat. The first major threat is distant metastasis, we saw in previous slides. The second major threat is the development of synchronous primary tumors. Because the upper aerodigestive tract is bathed in the exact same with the same carcinogens, the entire mucosal field is highly unstable. We clinically refer to this concept as field cancerization. This phenomenon leads to the simultaneous development of completely new independent tumors. These are not metastases from the larynx, but entirely separate cancers. You must actively hunt for both of these distinct threats before you finalize any treatment plan. Let us now proceed for step 7 in the evaluation of laryngeal and hypopharyngeal cancers. This is your laryngeal functional assessment. I will take a separate lecture on it. So friends, I end my lecture here. Do watch my next video on assessment of laryngeal cancer. Thanks for watching. See you in next video. Signing off, Parveen Ahlawat.